carcinogenesis. Some cancer cells have deficiency in this homologous recombination, especially also cancers with BRCA mutations. They have homologous recombination deficiency. And what does that mean? That means that they have accumulated DNA damage that renders them susceptible to DNA cross-linking agents like platinum therapy. That's why these patients respond wonderfully to chemotherapy, to platinum-based chemotherapy. So this score was developed by Marriott, and this score can predict whether the tumor has enough homologous recombination deficiency to respond to platinum. And it's still under clinical trials. Another thing that's very interesting is immune gene signature. So basically, recent studies have shown that the immune system, the human immune system, can play a critical role in fighting cancer cells. This has been tried in melanoma and has been proven successful. So basically, the immune system can kill cancer cells through T lymphocytes targeting an antigen that's called programmed cell death protein. And the researchers have found out, well, if we use antibodies that target this antigen, we can induce cancer cell death. And so basically the immune gene signature is a signature that tells us whether the tumor can be targeted through this type of therapy or not. And again, this is still tested in clinical trials. So there is a lot to think about, there is a lot to do. We are not at the end of the road, and definitely there is no clear-cut answer in the field of breast carcinoma, but I think there is hope, and these maybe in, I don't know, 10 or 20 years would be something that we do as routinely as ER/PR. Maybe I'm too optimistic, I don't know. So that's it. Any questions?
I want to ask about the possibility of progesterone receptors in terms of negative effect in the absence of estrogen receptor. Some authors consider that if progesterone receptor is positive, estrogen receptors also must be positive. And if this result is present, we must repeat the state. Because the progesterone receptors is estrogen receptor is a step in the pathway of formation of progesterone receptor. So the progesterone receptor is positive, estrogen receptor also is positive. Right. So sometimes some authors consider consider estrogen receptor positive even the results which we give is
right. So in the majority of cases, if progesterone receptor is positive and the estrogen receptor is negative, that's an indication to repeat the test for the reasons that you mentioned. That there is something wrong with the assay itself or the handling is not correct. So that's why we have only PR positivity. Well, the ER and this tumor is actually positive. However, some tumors might bypass this pathway and have only PR positivity, but this is to a much lesser extent. The majority of the cases, this is an indication to repeat the test or repeat it on the resection specimen or send a sample for O5DX to measure the actual estrogen receptor gene expression.
But it is permitted to report by report. Estrogen receptor is negative and progesterone receptor is positive.
You can do that, but after you have repeated the test and mention in a comment that, or you don't have to mention it in a comment, as long as you repeated the test, you are very sure that your controls work, there is tissue handling, the escapable ischemic time is less than 1 hour, fixation time is not more than 72 hours, everything is working, you can report it. And then the clinician has to think about providing you with a different sample, repeating the test on a resection specimen, or sending it for
Excuse me.
Yes.
Another important point, because it is written in some books that which we do routinely assess is alpha estrogen receptor, and there is alpha and beta. So when we find alpha estrogen receptor negative, we repeat for beta and it's positive. So this may be the cause that in some cases we find that ER negative and BR positive because we didn't assess for ER beta. What's your opinion?
My opinion is most of the antibodies that are validated and used for estrogen receptor test, they target the alpha.
Yes.
So the antibodies that can be targeting the beta, the estrogen receptor, are not as validated as the ones that target the alpha. So you cannot really rely on the test results of these antibodies. You have for the ER, PR, and HER2, you have to use FDA-approved tests, currently validated against clinically validated tests. So you can use it in the research center, and you can have results that are positive, but you cannot use it in the unless it's
not related to the hormone positive group, but rather to the negative group. And in that situation, if you do not consider them triple negative, they will lose the advantage of having the proper treatment. Maybe you want to give them PARP inhibitors, or maybe you would like to test for BRCA. And these particular group of patients who are very weakly positive for hormone, they will be proven to have a much higher BRCA mutation than the luminal groups, up to 40%. So this comes to the problem of insurance coverage. These patients are to be covered with insurance for the treatment of triple negative group, then they won't have it because definitely they are not defined as that. So in their publication, they're stating that this weakly positive group should actually be considered until proven otherwise, and that these patients are to be considered triple negative to have the complete sort of advantage of that group, and also to avoid the unnecessary effect of the 130, which is there. So actually, I look forward and I hope that patients with below 10% ER positivity should be.
Yes, thank you. That's an excellent comment. That's why there are studies that are trying to elevate the cutoff point from 1% to 10% exactly for this clinical scenario. And I encounter these patients in my practice, and I'm like 2%, 3%, and I ask my oncologist, so what do you do? Do you give them hormone treatment, or do you treat them like triple negative? And the answer is they treat them like triple negative. They know that the report says it's positive, but as long as it's less than 10%, they don't give them hormone treatment. But we're still there. We need it in the guidelines. Yes.
One of the recommendations of this paper that it is to be considered in the guidelines.
Exactly, yes. We're all hoping for that.
Well, unless it is in the guidelines, no one is really having the right to do it.
Yeah, we have to report what we're seeing, so exactly. Thank you. Any more questions? Thank you very much. Thank you. Well, I have a case presentation in case you're interested. I know what time it is. It's 5. So, should I give it? Okay, it's gonna go fast. This is actually pretty interesting. All right. So this is a case that I had from a 65-year-old female who presented for a second opinion for treatment recommendation of her newly diagnosed left breast cancer. They were thinking, is this recurrence of her, she has history of breast cancer in the same side, they were thinking it as recurrence versus new primary. Her initial cancer was ER positive, and they didn't do HER2 routinely back in 2001. Since 2001, she received the surgery, primary conservation surgery. She had a sentinel lymph node biopsy and completion axillary dissection, followed by post-operative radiation and endocrine therapy. She presented now, she did well for 12 years, and now she felt a breast lump in her axilla and presented for that. The imaging studies, including the mammogram and the MRI, were non-specific. They showed a speculated lesion at intermediate suspicion in the axillary area and recommended a biopsy. And this is the biopsy that we got. This is the lesion, this is a low power view. So I'm going to show you the images and we'll have the discussion. This is a low power view. Another area, low power view as well. Another field of the tumor. This is P63. This is calpomin. This is high molecular weight keratin 5 and 14. And this is, the ER/PR, HER2 were negative, mammoglobin and GCD-FP15, which are markers of mammary tissue differentiation, were negative. So, what is the diagnosis? Is it A, sclerosing adenosis arising in a radial scar, B, tubular carcinoma, C, seromdomatous adenoma, D, low-grade adenosquamous carcinoma? So we'll just, I don't know, I mean, we can just raise our hands. It's just one question. Who thinks, how many thinks it's A? How many think it's B? How many think it's C? How many think it's D? Okay, so fairly more or less the same number of people think it's either one of these options. So basically this is a low-grade adenosquamous carcinoma of the breast, and I will of course explain why I think so. The outside pathology report, so as I mentioned, this patient came for a second opinion. The outside pathology report stated that this is positive for adenocarcinoma, consistent with breast primary. They didn't do all the immunohistochemical markers I showed you. These are markers that I did after that. Except, of course, they did ER, PR, and HER2, it was negative, so they called it a triple negative breast carcinoma. They did the Ki-67 and it was 4%. So let me ask you this, what is discordant in this sentence? Triple negative tumor with a 4% Ki-67. It doesn't make a lot of sense because triple negative tumors should have high Ki-67. So that's the first thing that we should notice. And they did EGFR, c-KIT, Vimentin, and they were all positive, which goes with a triple negative profile. So, and they suggested that this is a basal subtype. Again, the triple negativity expression of EGFR, c-KIT, Vimentin, this all goes with basal subtype. The only thing that does not is the Ki-67. Okay. So what is low-grade adenosquamous carcinoma? As you all know, it has been published in the 2012 WHO that this should be considered a subtype of metaplastic carcinoma. And hence the expression of basal cytokeratins, EGFR, c-KIT, and Vimentin. This, from its name, adenosquamous, these carcinomas have distinct adenocarcinomatous component in addition to variable degree of squamous differentiation. Clinically, the patients, there's a wide age variation, 20 to 85 years. They usually present with a palpable mass, and the findings radiologically are not specific like in our case. Grossly, it presents like any other tumor, ill-defined borders, firm to hard consistency, and usually they are less than 5 centimeters. Now let's go over the pictures from our case. So here's one of the low power pictures. You can appreciate well-formed glandular structures haphazardly infiltrating the stroma. Note the angulated glands here. Some of them have the appearance of solid nests, like here. So we have both angulated glands and solid nests. This is a normal terminal duct lobular unit, and you can appreciate the solid nests percolating around normal breast tissue. So this looks like an invasive process, although it still could be sclerosing adenosis. But typically, the angulated glands, you do not see that much in sclerosing adenosis. This field of the tumor, basically, we're having a hard time telling where the tumor is and where the stroma is. So the infiltrative epithelial cells seem to intermingle with the stromal cells. The other characteristic thing about low-grade adenosquamous carcinoma is that the squamous differentiation. So this is one of the H&E pictures of one of the nests. Maybe you will not be able to appreciate it from the picture, but actually if you go to the highest power, you will see the intercellular bridges characteristic of squamous differentiation. And again, you see these solid nests with sort of like the intercellular bridges and the eosinophilic cytoplasm you see with squamous differentiation, juxtaposed to gland-forming tumor cells. The other characteristic histologic thing about this tumor is the stromal quality. See how these are tumor cells, sort of like haphazardly single or maybe microclusters. They typically have stromal cuffing, like around some of the glands. So you have both these are the stromal cells cuffing around the solid nest of tumor right there. So typically you see stromal cuffing. You can see it in this area here, and you can see it maybe in this area here. The other characteristic stromal feature is the dense collagen deposition and the fibroelastosis. The fourth characteristic histologic finding in this type of tumor is the prominent lymphoid aggregates at the periphery of the lesion, as you can see here. So this is the periphery of the lesion. You do not see that much, these lymphoid aggregates with radial scars typically. Here's another field with lymphoid aggregates. Low-grade adenosquamous carcinoma, as other metaplastic carcinomas, they can have osteocartilaginous elements, but it's rare. Usually you do not see coexisting DCIS or other regular types of invasive carcinomas, and their transition to high-grade metaplastic carcinoma is highly unusual. All right, let's discuss the P63. So these are pictures I showed from the case earlier. See, these are tumor nests here that completely lack P63 staining. Some of the tumor nests show some peripheral staining, and some of them, here again, completely lack the P63 staining, and some of them show luminal P63 staining. See these nests here? It's staining the luminal cells in the solid nests. So this is sort of like, well, that's weird, because if this is highlighting myoepithelial cells, it should be at the periphery of the tumor nest. Why is it staining cells in the center of the tumor nest? Right? Here's calponin, and typically you see lamellar pattern of staining. And again, some of the tumor nests lack the staining with calponin, some of them have it. Low-grade adenosquamous carcinoma also show a very weird pattern with keratin 7. Look at these tumor nests. It's staining with keratin 7. Some of them are not. But if you look carefully, you're going to see stronger staining in the center with decreased staining at the periphery. This is kind of peculiar. The periphery is still expressing the stain, but to a lesser extent. And we saw this slide that showed high molecular weight keratin positivity, keratin 5 and 14. Here is the high molecular weight. So typically, if this is sclerosing adenosis or a low-grade breast carcinoma, it shouldn't stain with high molecular weight keratins. But this tumor obviously is. And typically, they have triple negative biomarker profile like we saw. Additionally, they express EGFR, c-KIT, and vimentin like other basal-type carcinomas. So the golden rule to diagnose low-grade adenosquamous carcinoma is consistent inconsistency. Basically, this is referring to the myoepithelial marker pattern of staining. So some of the tumor nests completely lost the P63, some of them are showing focal P63, some of them showing P63 inside the tumor nests. So it's consistent inconsistency. So to summarize, the H&E findings in this entity, it's an infiltrative growth pattern like we saw. They typically percolate around normal breast ducts. They have a radial scar-like background. They're radiating fibroelastotic bands. You're going to see the focally angulated glands, the solid nests with a subtle squamous differentiation that is highlighted by P63 because P63 is a marker of squamous differentiation. And you're going to see the cellular stroma with cuffing around the tumor cells, the desmoplastic look, collagenous fibers, and fibroelastotic areas. And if you're lucky, you're going to see the peripheral lymphoid aggregates. And then to summarize the immunohistochemical findings, these tumors typically express high molecular weight keratins 5 and 14, keratin 7 in a patchy variable intensity and peculiar distribution, more so in the center of the tumor cells than the periphery. The P63 and the calponin inconsistently stain the tumor nests with P63 staining or highlighting the cells with a squamous differentiation. And then all the ER, PR, and HER2 are negative. So why is it significant to think about this entity? Okay, so although they belong to the basal group, these tumors have indolent behavior and excellent prognosis. These patients should not be given chemotherapy. Lymph node involvement is extremely rare. Only one reported case of systemic involvement in a 33-year-old with, she had a huge tumor, and that's why she had lymph node involvement and metastasis to the lung. They more commonly act locally aggressive, but they do not metastasize in the majority of cases, especially if they are less than 3 centimeters. The treatment, therefore, is just surgical excision with free margin. Radiation and chemotherapy should not be indicated in these patients. So it's a sort of a controversial entity. So what is this low-grade adenosquamous carcinoma? Where did it arise from? Some people suggest it arrived from eccrine or sweat gland origin. Some people say, well, because of the P63 and the squamous differentiation, they came from myoepithelial cells. And then the third theory is that it's just reactive, which is a little bit crazy with the metastasis, with the cases that have documented metastasis. And these are basically the different research groups that sort of like trying to hypothesize where they came from. I'm sorry, yes?
That's carcinoma.
but has excellent prognosis. So that's why it's very interesting. And that's another reason why they fall under the Basal-like genotype. They have the same chromosomal gains and losses that are observed in the EGFR receptor gene amplification observed in basal type carcinomas. It is a weird tumor. I told you it's interesting. And this is just again going over the basal cytokeratins expressed and shared with basal subtype. One thing to remember is the EGFR overexpression is significant independent prognostic factor in these tumors, as well as c-KIT expression. And well, I'm just talking about in general basal-like breast cancers, not low-grade adenosquamous carcinoma. So the only thing that made me think about low-grade adenosquamous carcinoma initially is that this tumor has a low Ki67 and expresses basal markers. So if you find a tumor that looks histologically low-grade, is triple negative, low-grade tumors should be positive for ERPR, and low Ki67, think about low-grade adenosquamous carcinoma. Typically, other types of basal-like breast cancers have aggressive behavior, poor prognosis, all patients are given chemotherapy, but in this tumor entity, patients should not be given chemotherapy. That is sort of like the pitfall. Remember, the initial pathology report said that this is a triple negative tumor, basal subtype, and has aggressive behavior. This patient was going to receive chemotherapy. So if you think about this entity, you save the patient from receiving unnecessary chemotherapy with, a lot of toxicities. You could just have a lumpectomy and have excellent prognosis. Now, to discuss the other differential diagnosis, fibrosclerosing lesions or radial scars, they have the same background, and the occasional cases may undergo squamous metaplasia. However, let me show you something. This is the histologic grade of typical radial sclerosing lesion or radial scar with the central fibroelastotic nidus and the radiating ducts usually expressing usual ductal hyperplasia. You can find also papillomas, intraductal papillomas, typically radial scars at the periphery. However, to differentiate between radial scar and low-grade adenosquamous carcinoma is radial scar will show strong complete staining of the